Good morning, good afternoon, and good evening, depending on your location. On behalf of IACH, I welcome you all to IACH post-ASCO EHA webinar on MDS and AML. It will be presented by our friend, colleague, and well-wisher, Professor Ahmed Zaidan. Professor Zaidan is a professor of internal medicine. He's also a chief of division of hematological malignancy, Director, Early Therapeutic Research and Medical Director of Clinical Trial Office at Yale Cancer Center. He's a global leader in the field of myeloid malignancy. He led multiple global clinical trials in the field, which leads to approval of many drugs in the field, and it helped our patient. He has co-authored more than 400 publications in the field, and most importantly, he holds several leadership positions at the National International Scientific Committee on Myeloid Malignancy. Professor, thank you, and floor is yours.
Thank you so much, Dr. Savani, and it's a true pleasure to be here with you today, where I'm going to be talking about highlighting, I think, some of the interesting abstracts for MDS and AML, both presented in ASCO and EHA 2025. So these are my disclosures. And what you can see here is an outline of the abstracts that I'm going to talk about today. So I just want to start by kind of emphasizing that there are very, I think, important studies presented in both ASCO and EHA, and it's always very challenging to choose what I would say are the most important abstracts. So this is a little bit subjective kind of assessment, but these are the abstracts that I thought are most relevant for AML, which were more, I think, than what we have for MDS. So I'm going to be covering 6 abstracts in AML, covering the trials that you can see listed here. Phase 3 trial of 7+3 plus minus dasatinib, the ASCERTAIN-V study of double oral therapy with decitabine and sidazordine with venetoclax, and then actually a number of menin inhibitor trials, which, as many of you know, are the most kind of promising drugs out there for AML, looking at ziftomenib, liximenib, and revumenib. For AML, I'm going to cover 2 abstracts that were, I think, particularly important. One is the use of the cleaver-1 bixmarelimab in high-risk MDS, and an update from the COMMANDS trial in lower-risk MDS. And these are my disclosures. We'll start with AML. So AML, we have had an amazing progress in AML since the year 2017, after many years of really very little development since the introduction of 1973 through 2017. But then starting in 2017, we have 14 new drugs approved in AML. The latest drug to be approved at the end of last year was the first menin inhibitor, revumenib. And I think the field continues to be very energized, and many drugs are in testing, as I'm going to show you in the next few slides. So the first study I wanted to start with was presented in EHA 2025 by Dr. Donor on behalf of the AML German group, which is a phase 3 study of intensive chemotherapy plus minus dasatinib in core binding factor acute myeloid leukemia. So as background, many of you know that core binding factor leukemia is an important subset of patients with acute myeloid leukemia. KIT mutations are actually quite prevalent in those patients, and prevalence varies from 30 to 70% of them, depending on the study. But even the ones which don't have the mutation have high KIT expression. And the mutant KIT has been associated with worse outcomes in patients with the core binding factor leukemia. And there has been an interest in adding therapies on top of the 7+3 or the intensive chemo backbone for those patients. One of those drugs was dasatinib, which has activity in addition to being used in CML for BCR-ABL. It has an activity against KIT, both wild type and mutant. And there's preclinical data supporting the use of dasatinib for KIT mutant disease, as well as synergy with intensive chemo with cytarabine. And there was actually also a single-arm phase study that suggested that adding dasatinib to intensive chemo could be associated with improved outcomes in patients who have mutant KIT core binding factor leukemia. To try to kind of test this study or this concept formally, the German group conducted a randomized phase 3 trial in which patients who were adults and with core binding factor AML were randomized to receive induction chemo versus induction chemo in combination with dasatinib. Dasatinib was started at 100 milligram dose on day 8 through day 21 and was continued through consolidation with high-dose cytarabine and subsequently in a maintenance phase. And the primary endpoint was event-free survival. And what you can see here is that the response rate to both of those arms were high. The CR/CRI rate was above 90%, but there was really no significant difference, as you can see, in terms of the responses between the dasatinib and the standard arm. Actually, when you look at the CR rate, it appears a little bit lower, 55% in the dasatinib arm compared to 65%. But there was no difference in refractory disease or in 30-day mortality, and in the rate of patients who proceeded to undergo bone marrow transplant. For the primary endpoint of the study, the event-free survival, you can see here there was no significant difference, again, between the two arms, and there was also no difference in overall survival using the log-rank test, or when you look at the 4-year event-free survival and 4-year over survival between the two arms. And in a pre-specified subgroup analysis for event-free survival, looking at patients who had KIT mutation, you can see here that there was really no significant difference in survival, even or in event-free survival, even among patients with KIT mutation. So in conclusion, the addition of dasatinib to intensive chemotherapy in core binding factor AML did not improve response or event-free survival or overall free survival, including in patients who have KIT mutation. And I did not show you the adverse events, but there were more adverse events in patients who have, of course, added dasatinib to the therapy, most commonly being febrile neutropenia and infections. So I think this trial gives a very clear answer about the role of dasatinib in combination with intensive chemotherapy for core binding factor leukemia, which is really none. We should not be using this drug anymore. Of course, many of us use gemtuzumab based on a number of randomized clinical trials in combination with 7+3. And I think this continues to be the standard of care for patients with core binding factor AML, whether they have KIT mutations or not. The second abstract I wanted to cover is in the evolving, I think, exciting area of total oral therapy. This is an abstract that I presented on behalf of the authors in ASCO 2025, and my colleague, Dr. Robas, presented a similar abstract in EHA 2025. This abstract basically focuses on the use of oral version of decitabine called decitabine sidazoridine plus venetoclax in patients with acute AML or acute myeloid leukemia who are not candidates for intensive chemotherapy. So for background, many of the audience know that in AML who are older than 75, who are unfit for intensive chemotherapy, the standard of care has been venetoclax with azacitidine or with decitabine or low-dose Ara-C. All of these are approved in the US, but worldwide, venetoclax with azacitidine. And this was based on the VIALE-A trial that showed improvement in survival with Ven-Aza compared to Aza alone. But we also know that while decitabine is not approved in combination with venetoclax in many countries outside the US, there is actually a lot of data suggesting clinical comparative equivalence between azacitidine and decitabine. I think one of the largest analyses you can see here is from the Astral-1 study. This was a study that randomized patients to receive decitabine, azacitidine, or low-dose Ara-C versus getting a second-generation hypomethylating agent called goa-decitabine. The study was negative, but we took advantage of the fact that we had many patients who received azacitidine and decitabine at the physician choice. and we compared the overall survival, the 1 year survival, 2 year survival, and you can see complete overlap between azacitidine and decitabine. So I think this is clear that there is no significant difference between these two hypomethylating agents. And we also know that there is an oral version of decitabine called oral Dixi or decitabine sidazoridine, which has been approved in the US for high-risk MDS and actually approved as monotherapy for AML in Europe based on pharmacokinetic equivalence to the IV formulation, where you can see here 99% based on the ascertain trials for high-risk MDS and for AML. And lastly, we know that there is a strong preference to use oral therapies whenever possible because it's associated with lower treatment burden, and an oral regimen would be associated also, I think, with patient benefits and reducing kind of chair time in our very busy infusion suites. So based on all of this data, we designed this phase 1/2 trial to combine oral decitabine with venetoclax in patients who are older than 75. And what we reported in ASCO 2025 was the pivotal part of the study, which is the phase 2 part B, which combined oral decitabine given in day 1 through day 5 at this approved dose, which is 35 milligrams of decitabine and 100 milligrams of decitabine. And this was combined with venetoclax, which was started at 28 days, but was reduced later based on the response and the cytopenias as a standard for venetoclax. And the primary endpoint was a complete response rate. And the study was powered in a way to indirectly compare to the complete response rate that is expected with decitabine alone, which is around 18%. So based on this, we enrolled 101 patients to receive the combination therapy. Venetoclax was escalated in a typical ramp up, 100, 200, and then 400 starting day 3, and the patient continued on 300 on the 400 dose. And patients received a bone marrow biopsy to decide on how much venetoclax should have been continued. Treatment was continued until disease progression and acceptable toxicity, or if the patient withdraws from the study. So here you can see the baseline characteristics of the 101 patients. You can see clearly it's a typical age for AML patients. Median age is 78. Patients were primarily males, and there was equal distribution in the cytogenetic risk groups between favorable, intermediate, and adverse risk. And there were around 15% of patients who had TP53 and 13% who had NPM1 mutations. So the first conclusion we had from the study is that there was no interaction between decitabine and venetoclax. So there is no pharmacokinetic interactions, and that allowed both drugs to be delivered at the normal doses without any issues. Importantly, as I mentioned, and as is common for venetoclax, the dose of venetoclax, which you can see here in blue, was being reduced by the investigators to adjust for the cytopenias, while this was to a much kind of more common approach than reducing the oral decitabine, which was reduced a little bit, but not as much. But as you can see in the figure, most patients beyond cycle 6 basically landed with around 12 days of venetoclax rather than the full course, which was used initially. And the trial met the primary endpoint where the CR rate was 47%, as you can see in this figure. The CR was durable. It was basically not reached. The median duration of CR was not reached at the time of the data cut. 75% of patients were still in CR after 12 months, and the survival was 15.5 months in the phase 2B, which actually is in line with what you expect with VIALE-A trial for aza-ven. When we looked at subgroup analysis, we showed consistent results across the different basically geographies and different demographic as you can see in this figure. And on the safety front, we saw again very similar results to what was seen with the VIALE-A study. The 30 and 60-day mortality was 3% and 10%, which is in line with what was seen with VIALE-A, which was around 7%. The most common adverse event were febrile neutropenia and cytopenias, myelosuppression, but there was a very low rate of treatment discontinuation due to adverse events. And I think the data overall supports the use of oral decitabine and venetoclax as an alternative for AZA and VEN, total oral therapy for patients with the newly diagnosed AML who are not candidates for intensive chemotherapy. And I think this regimen is certainly, I think, going to be received by patients in a more welcome fashion than AZA, where they have to come 7 days every month to receive the injections for the rest of their lives, because most of those patients are treated until progression and they generally will not go to transplant. So this data has been submitted for regulatory review, and hopefully this regimen would become available for our patients in the US in sometime in 2026. Now moving to, I think, another promising group of drugs, the menin inhibitors. And there are a number of those menin inhibitors, and I think there were important updates on monotherapies as well as combination therapies for several of those menin inhibitors. The first one I'm going to talk about is ziftomenib. And ziftomenib was basically covered in 2 trials in ASH, in EHA and ASCO, one as a monotherapy in the relapsed refractory NPM1 mutated AML, and the second study was in combination. So we'll start with the relapsed refractory study. Ziftomenib basically is an oral, highly potent menin inhibitor that's given once a day, that has very little drug interactions with antifungals, does not cause CYP inhibition or QTC prolongation, and therefore it's an ideal drug to be given for patients with refractory AML. And what was presented in ASCO was an update from the pivotal registrational study for ziftomenib as monotherapy that looked at ziftomenib as at the identified dose of 600 milligram PO daily, and this was a COMET-001 study. Of course, the study was conducted in patients initially with NPM1 and KMT2A rearranged leukemia, which are the 2 populations that benefit the most from menin inhibitors. But the pivotal part of the study, the phase 1b expansion and phase 2 registration enabling, was conducted in NPM1 mutated patients. And the primary endpoint, as you can see, was the rate of complete remission or complete response with partial count recovery. And the patient population that, as you can see in this figure of this phase 1b/2 study, which had 112 patients, was typical for AML, where you can see most patients were older than 65. Around 2/3 were older than 65. But importantly, those are patients who have received multiple therapies. The median number of prior therapies was 2. Around 1/4 received bone marrow transplant, and around 60% have received venetoclax. So this was, I think, a heavily pretreated patient population. But despite this, as you can see here, the trial did meet its primary endpoint of the phase 2, which was improvement in the complete response rate, as you can see here, and complete response with partial count recovery over the historical rate of around 20%, as you can see, 12% historical rate. And you can see here that the CR/CRh was 23% in the phase 2, and in the pool phase 1b/2 was 25%. And the median duration of the response, you can see down in the table, was around 3.4 months. And many of those patients achieved MRD negativity, around 2/3 of those patients. And the responses were generally, the best response was achieved with a median time of 2.5 months, 2.8 months from treatment start. And I think what was interesting is that the CR/CRh rates were still good when you look at pre-specified subgroups, including those who have received prior transplant or prior venetoclax, and generally regardless of the prior mutations. And when you look at the overall survival analysis, The median overall survival was 6 months in this highly challenging patient population with multiple prior therapies, venetoclax, transplant, etc. But among patients who were responders who achieve any kind of response, you can see that the median OS was 16 months compared to 3.5 months for non-responders. So certainly this drug is associated with clinical benefits, but importantly, on the safety side, I think the drug also was associated with a well-tolerated side effect profile, where the rates of immune or myelosuppression were low, and there was a very limited number of Q2C prolongation that were generally associated with other causes, as well as very rare occurrence of differentiation syndrome that was generally well managed with steroids and treatment interruption, but there were no grade 4 or 5 differentiation syndrome in this pooled phase 1b2 analysis, and the rate of discontinuation due to adverse events were low. So in summary, the primary endpoint of this registrational part of the COMET-001 study was met, where ziftomenib achieved clinically meaningful CR/CRh rates around 23%, many of them MRD negative, in a heavily pretreated refractory relapsed NPM1 mutated patient population with low rates of QTC prolongation or adverse events leading to treatment discontinuation or differentiation syndrome. And based on these data, the drug also has been submitted to the regulators to hopefully have this as an approved treatment option for patients with the relapsed refractory AML. Now moving to another, I think, exciting menin inhibitor, which is bleximenib. So here, rather than in monotherapy, where the drug is also advancing, what was reported in EHA 2025 is a phase 1b study called the Ali 1002 study, presented by Dr. Andrew Way on behalf of his colleagues, which was a combination study with venetoclax and azacitidine. And this was in patients who were in the refractory relapse setting or in newly diagnosed AML with the KMT2A mutations or translocations or NPM1 mutations who were not deemed to be candidates for intensive chemotherapy. So bleximenib is another potent selective oral menin inhibitor that has shown activity as monotherapy. And this was the reason why it was moved forward in this trial to be tested in combination with azaven. And last year, actually, there was also data presented in combination with intensive chemotherapy. And this drug, compared to ziftomenib, is given twice a day. So here you can see the dose escalation part of this study in combination with venetoclax and azacitidine. You can see that this was conducted both in the relapsed refractory and the newly diagnosed patients. And the dose that was selected was 100 milligram PID, which was selected to be the dose used for expansion. Here you can see the responses. So the response rate was, I think, interesting, especially in the newly diagnosed patient population. So if you look at the newly diagnosed AML in combination with azaven, the composite CR rate was 65%. The composite CR rate was 75%. Of those, 65% were CR or CRh, as you can see here. However, the sample size was relatively small at 20 patients, and this was using the target dose of 100 milligram PID. In the refractory relapse setting, as you can see to the left, the activity was not as good. But I think the activity in the frontline setting certainly was interesting. And based on this, actually, the sponsor is initiating a large randomized phase 3 trial called the CAMELOT-02. You can see the design of this trial in this slide that was also shown in the oral presentation. So this is a phase 3 trial that actually already enrolled some patients, and it's randomizing 600 patients to receive bleximenib with aza and venetoclax versus aza and ven with a placebo, with a primary endpoint of CR and OS. Now, the other menin inhibitor that's already approved in the US, actually, or the only one that's approved to date, is the revumenib. This drug is approved as monotherapy for KMT2A-rearranged leukemia, both actually AML and ALL if they have that rearrangement, as well as in adults and children. However, what was presented in EHA with a concomitant publication in JCO is the triplet of azacitidine with revumenib in patients with acute myeloid leukemia with NPM1 or KMT2A rearranged leukemia, which was a Beat AML study. You can see here the design of this phase 1B study. There was 2 dose levels that were tested. Revumenib, similar to bleximenib, is also given twice a day. And because this drug is actually significantly affected by QTC interactions, significantly affected by cytochrome 3B interactions, there's a need to adjust the dose based on fungal use, which is important to note. And also there is a concern about QTC. So 2 dose levels were used in this study in combination with revumenib, with azacitidine and venetoclax, and the patients were continued if they responded until progression or transplant. So during the conduct of the study, they noticed 1 hematologic DLT during dose level 1, and ultimately they also noticed some cases of differentiation syndrome. But again, this was well managed, and there was no grade 4 or higher differentiation syndrome or QTC prolongation, and there were no discontinuation of revumenib due to these differentiation syndrome or QTC. So while these can occur, they seem to be manageable. And 30 and 60-day mortality was 7%, which is in line with what we see with Verona trial. So in terms of the clinical results, you can see that the combination of both dose level 1 and dose level 2 across both KMT2A and NPM1 was associated with a CR rate of 67%. And the CRH of 2.3%. So this is actually does not seem, as a combination of CR plus CRH, does not seem very different from what was seen in the bleximenib study that I just showed you with the other menin inhibitor. So I think it seems, again, there is a lot of overlap in terms of clinical efficacy between these menin inhibitors, and logistical considerations about once a day versus twice a day, QTC prolongation, issues related to drug interactions might become, I think, more important in how we choose these drugs. But also, I think an evolving area is what the different mutations that can happen within the menin protein can also potentially respond to certain menin inhibitors and not others. But I think it's quite exciting to see a number of those menin inhibitors kind of move forward in development. So this trial again showed that the combination is feasible of revumenib with azacitidine. And based on this, similar to the bleximenib study, this is also going to a phase 3 trial called the EVOLVE-2 trial, which is a randomized phase 3 study, which will randomize patients to receive azacitidine revumenib versus azacitidine placebo in NPM1 and KMT2 rearranged AML. And lastly, the last study for AML and the last study for a menin inhibitor that I will be talking about today was the combination of ziftomenib, the menin inhibitor I mentioned earlier, where we showed the data in the refractory relapse setting as monotherapy. Here we presented, or Dr. Harry Erba presented on behalf of the authors, a study randomizing patients to receive ziftomenib in combination with 7+3 as part of the COMET-007 study, and that was both for NPM1 or KMT2A rearranged AML. This is the design of the study, which included, again, a dose escalation of ziftomenib 100 milligram, 200, 400, and 600 milligram. And eventually, the 600 milligram was the dose that was selected for expansion in combination with intensive chemo therapy. And here you can see that the combination of 7+3 with intensive chemotherapy was associated with very high response rate in the 71 patients who were response evaluable, where the CRC rate was 93% for NPM1 patients, the 44 patients, and the complete response rate was 84%. Same thing for KMT2A rearranged AML, where the overall response rate was 89% and 74% CR. And many of those were actually more than 60 to 70% were MRD negative using local assessment. And it did not seem that the addition of ziftomenib to the intensive chemo is leading to a delayed count recovery, as evidenced by the time to recovery of ANC above 1 or platelets above 100, which had a median of 32 days for ANC and 29 days for platelets. And this also is in combination with other safety data that I don't have the time to show you all the safety data. But in general, the myelosuppression was not beyond what you see with 7+3. As we already mentioned, differentiation syndrome is relatively rare, and it's generally successfully managed in the setting of combination therapies. But importantly, there is very little QTc prolongation and minimal drug interactions. And based on I think the very good promising data in combination with 7+3, we have initiated the COMET-017, which is a randomized two studies in one protocol of ziftomenib in combination with 7+3 versus 7+3 with placebo in patients who are fit for intensive chemotherapy for patients who have NPM1. And in patients who are not fit for intensive chemotherapy, you can see here, actually, let me rephrase, sorry. For patients who are intensive chemotherapy candidates, 7+3 plus minus ziftomenib or placebo, this will be in NPM1 and KMT2 arranged leukemia. While for patients who are receiving non-intensive chemotherapy, with azacitidine, it would be plus minus ziftomenib or placebo, and that would be in NPM1 mutated patients. And the details of these abstracts or this study is provided in this trial in progress abstract. Now moving to high-risk MDS and lower-risk MDS, where I actually don't have a lot of kind of studies to present. There were some updates from ongoing phase 3 trials and some early data about some new drugs, but I think I decided to go only with 2 abstracts for the sake of time. We know already that high-risk MDS has been a graveyard for drug development in combination with azacitidine, and therefore azacitidine as monotherapy continues to be the standard of care, although we do use ivosidenib as a salvage drug in refractory relapse disease in patients who have IDH1 mutation. The problem is that this mutation happens in less than 5% of patients. So what you can see here is that there is a long list of combinations that look promising in single-arm studies, but once we have gone to the randomized phase 2 or phase 3 trials, those trials have failed. And the question is this related to bad drugs or bad trial design? I think this is something that we continue to debate, but I think this contribution of bad drug versus bad trial varies significantly depending on the drug. But the last 6 failures with pivonidistat, magrolimab, sabatolimab, tamibarotene, and most recently, as many of you have heard, the Verona trial with venetoclax has also failed. However, what was presented in EHA and actually ASCO was, I think, a promising antibody, which I'm excited about, called bexmarilimab, which is an anti-cleaver-1 in combination with azacitidine, both in the front line and the second line in patients with high-risk MDS. So just as an introduction, because many people are not familiar with the target here, so cleaver-1 is a novel macrophage checkpoint inhibitor. This drug has been, bixmarelimab is a novel monoclonal anti-cleaver-1 IgG4 antibody. And the use of this bixmarelimab has been shown to convert macrophages, which express cleaver-1 from an dormant state to a pro-inflammatory anti-cancer state, along with activation of the T-cell response, and also potentially can affect the blast cell energy production in blast from MDS. And based on preclinical data, this was taken forward in a combination study with azacitidine in patients both with newly diagnosed high-risk MDS and also refractory relapse MDS and CMML. And the initial part of this study, the dose escalation, was actually already published in Lancet Hematology. What was presented in EHA 2025 was an update of this study that focused on the dose optimization using the 3 milligram per kilogram phase of the drug. So what you can see here is that the drug is safe in the 53 patients that were presented in the combined analysis. The discontinuation rate due to bixmarelimab-related adverse events were very low. Only one patient discontinued. There were 3 grade 3 treatment emergent adverse events, basically this, but all of them were at the higher dose at the 6 milligram per kilogram, with 1 pneumonia and 2 cases of sepsis, and no grade 5 bixmarelimab-related adverse events. And the immune-related adverse events were generally rare and manageable. And the most common adverse events seen were myelosuppression and fatigue. And based on all of these safety data, the 3 milligram per kilogram dose was advanced forward for additional studies, because also it was associated with the clinical responses that were similar to the 6 milligram dose. So you can see here the dose impact on the response, and most patients had kind of responses with any of the doses at similar levels. When you look at the details of the responses among the frontline treated patients, which were 20 patients, and many of those are still on trial, so some of those responses are still evolving, the composite CR rate by the 2023 criteria was 50%, which appears higher than what you expect with azacitidine monotherapy. But importantly, the 2006 criteria, also the overall response rate was 85%. In the relapse refractory setting, the composite CR was 16%. But remember, again, this is a highly resistant patient population that has already failed hypomethylating agents. So any kind of response in the refractory relapse high-risk MDS study is encouraging, especially that those patients have been already exposed to azacitidine. When you look at the overall response rate was 47% in the HMA failure setting of 32 patients. Interestingly, I think the overall survival signal was very encouraging in the relapse refractory setting, which was 3.5 months as a median. Remember, in refractory relapse high-risk MDS, the median survival is generally in the range of 6 to 8 months. But also interestingly, that patients who had TP53 mutations had a median OS of around 9 months, which again is encouraging in the relapse refractory setting compared to historical controls. And finally, it seems that there was a good a trend for correlation, basically between expression of cleaver-1 on the bone marrow monocytes in correlation with the subsequent responses, as you can see here, as determined by International Working Group 2006 or 2023. So in conclusion, bixmarelimab with AZA seems well tolerated in high-risk MDS, both in the front line and the second line setting. No grade 5 bixmarelimab-related death among 53 patients with high-risk MDS. The adverse effect profile is generally manageable. Few discontinuations due to treatment-emergent adverse events, and promising efficacy data when it comes to responses, as well as overall survival in the refractory relapse setting, as well as the overall response rate and the complete response rate, composite response rate in the frontline setting. And based on these, I think, encouraging data, the sponsor is moving to a phase 3 trial in that setting. So more to come on this drug. And the last abstract I wanted to highlight from both, again, ASCO and EHA. In the EHA version, it was presented by Dr. Santini. This was a follow-up from the COMMANDS trial that looked at overall survival. So as a reminder, luspatercept is an approved erythroid maturation agent, which improves erythropoiesis. And the primary analysis of phase 3 trial of the COMMANDS had shown improved transfusion independence rate with luspatercept compared to EPO-alpha. And this led to the approval of luspatercept as a first-line treatment among transfusion-dependent patients with lower risk MDS, regardless of whether they have ring sideroblast or not. What was presented in ASH, on EHA, was an update on overall survival and long-term duration of responses with a longer median follow-up of more than 2.5 years. So this is a quick reminder of the design of the COMMANDS. As I mentioned, it was a randomized 1-to-1 study between luspatercept and EPO-alpha with a primary endpoint of red blood cell transfusion independence for 12 weeks, combined with a hemoglobin rise of 1.5 grams per deciliter. And this included adult patients with lower risk MDS who had 2 to 6 units of blood per 8 weeks, but were ESA naive. So this was a frontline treatment, and they had an EPO level of less than 500. So this does overall survival update from this trial. You can see an emerging trend in favor of luspatercept, favoring the overall survival with luspatercept, and the curve seemed to start separating after 2.5 years in favor of luspatercept. And when a subgroup analysis of overall survival was looked up to try to identify groups of patients who might benefit more, it didn't seem there were any specific groups that benefited more. You could see this signal in favor of luspatercept across the different groups, regardless of the transfusion burden or the EPO level. But importantly, also among patients who were RS negative, as you can see. So it's not only in RS positive, but also in some of the patients who had RS negative disease. And also the durability of the response with this longer follow-up of the study was still noted. So among the patients who achieved the primary endpoint, which was 12-week, the patients who have 12 weeks or longer transfusion independence, you can see that this was durable with 76% compared to 55.8, 76 weeks compared to 55 weeks with an odds ratio of 2.8 in favor of luspatercept. So with that, I think this continues to highlight the increasing kind of evidence of clinical activity with luspatercept from the COMMAND trial, where beyond transfusion independence, we are seeing a trend for overall survival improvement, where median OS was not reached for luspatercept, and a 20% lower risk of death in luspatercept compared to patients who received EPO-alpha. And this was seen across the different subgroups, regardless of the RS status, EPO level, and transfusion burden, as well as durable responses among patients who achieved the 12-week transfusion independence. With the longer follow-up, many of them were still in active, ongoing response. And I think this clearly supports the use of luspatercept as a frontline treatment in transfusion-dependent lower-risk MDS. And with that, I'd like to thank you so much for listening in, and happy to take some questions. This is my Twitter handle and my email, and happy to take any questions. Thank you so much.
Thank you. Thank you so much, Professor Zeidan. As expected, we can see your global popularity with numbers of questions we have received. I don't think we have enough time to take all the individual questions, but we'll try my best to incorporate and summarize some questions. So first question is, it's on a KIT mutation abstract you presented. Any analysis based on type of KIT mutation and response rate?
Yeah, not to my knowledge, or at least it was not presented during the presentation by Dr. Donor. But I suspect they might be kind of discussing that during the manuscript stage or subsequent presentations from that trial.
So next question, there are a couple of questions on menin inhibitor. In the menin monotherapy setting, patients who have co-mutation like FLT3, are these patients also achieving CR? Which one is upstream mutation? That's indirect question thing.
Yeah, so I think the question is referring to the subgroup analysis with the monotherapy registrational part of the study, where among patients who have ITD, the CR or the CR/CRh rate appeared lower in patients who had FLT3 ITD. But I think the numbers are just so small to make like solid conclusions in that particular setting. And I suspect many of those patients have seen also FLT3 inhibitors as part of their prior therapies, which probably makes them less likely to respond.
So similar question, but different way. In a patient with FLT3 and NPM mutation, which clones are normally arising at the time of progression after initial CR?
Yeah, this is another good question. So I think the question is alluding what do you do with these patients? So we clearly have approved FLT3 inhibitors. There are two of them now approved in the front line setting, quizartinib or midostaurin. And now we have, I think, the increasing data about the use of menin inhibitors. Right now, the intensive chemo trials are excluding patients who have FLT3 mutations because technically there's a standard of care which allows the use of FLT3 inhibitors. However, there's actually a part of this COMET-007 trial that will allow a quadruplet. So we are going to give 7+3 plus quizartinib plus ziftomenib. So this way you are going both after the FLT3 mutation as well as the NPM1 mutation through menin inhibition. And I think there is still an ongoing assessment on the kind of mutations that evolve with this kind of therapy. We have not kind of published this analysis yet, but it's still being conducted.
So next question, which is common day-to-day practice question is, how do AML patient feels regarding mode of delivery, IV versus sub-Q versus oral? Does that matter when making a treatment decision choice?
I think so. I think the main thing, in my opinion, is not the sub-Q or the IV or oral. It's the fact that they have to come to the clinic to get it. Like, so to get an IV or sub-Q, at least in the US, you have to come to the infusion center, which, you know, for many patients could be a 2-hour drive. They have to park, they have to wait, they have to get blood work. So that could be almost half a day or a full day affair just to get azacitidine. So when you do that for 7 days in a row every month, and remember, those patients with older unfit AML, their average survival is around 15 to 18 months. So if you are taking almost 7 days of each month to come to the clinic and spend this entire time, I think most patients will immediately tell you, I prefer to have oral therapy, especially when they are in remission and they don't need transfusions. But these kind of analyses about patient preference and treatment burden and healthcare utilization, etc. All of them, I think, are going to be very important to give like evidence-based answers. But I think, in my opinion, all patients will prefer oral therapy. I just want to give one caveat is that the insurance setup in the US and the copays sometimes could have the patient pay much higher copay if they get an oral drug versus IV or sub-Q. And unfortunately, this can affect the patient choice, even if they prefer oral. If they have to pay a huge copay, they probably still kind of reluctantly agree to come to the clinic to get IV or sub-Q.
This is one more question on menin inhibitor. Do you feel menin inhibitors are best used as a mono or combo therapy? Also, if the clinical data is similar, what can set them apart?
No, I think both of those questions are great. I strongly believe that the best benefit from menin inhibitors is in the combination setting. Clearly, I think we are seeing very nice responses in the refractory lab setting. Revumenib is already approved. Ziftomenib has very nice data as monotherapy in the refractory lab setting with NPM1 disease. The response data, and again, is very tough always to compare trial to trial, but the CR rate, CR/CRh is around 20 to 30% with a median OS is around 6 months with most of these kind of analysis. But this highlights that treating the patients when they already relapse and have received transplant or venetoclax, etc., I think is very late in the game to try to get very durable responses. So I think the best value is to try to move these drugs up front and combine them with standard of care therapies. This is a model that I think worked very well in other hematologic malignancies, in multiple myeloma, in CLL, and even in AML, other like FLT3 inhibitors, IDH inhibitors. We have seen similar trends, and we saw, I think, clear signal for combination once we move to the frontline setting. So I think combinations in the frontline setting. The second part of the question is how can you differentiate? Again, we have revumenib, we have ziftomenib, we have liximenib, and there's another one actually did not talk about because there was no presentation in ASCO or EHA called enzomenib. So there are 4 of them that are in well advanced in clinical trial, but there is a bunch that are still in phase 1. So there are going to be a lot of them. I think unless there are clear signals for clinical differentiation, I think it's going to be clear that logistical factors, and I strongly believe in that for drugs that you have to take for years and years, like taking a drug twice a day, for example, is a much bigger pain for patients. They will forget it. They will not be compliant compared to once a day. Drug interactions, for example, I think also are another thing. If, revumenib, one of the problems with it is that it has significant CYP interactions with antifungals, and you have to be very careful if, let's say, if the patient is getting a drug from their cardiologist or primary care, you have to double check that there is no significant interaction. And then you have the QTC issue, which again can be a nuisance, but sometimes it can pose real risks if a patient was given another QTC prolonging drug on top of it. So I think these factors might become important, but other factors I think are going to become important in the future, such as the specific type of the mutation that evolves, similar to what we see with CML now. Like there are certain mutations in APL kinase that are susceptible to different kinds of inhibitors or based on certain comorbidities that the patient have. So I think it's a very exciting, evolving field. But at the end of the day, I think having multiple options is probably good when you have competition and, you have multiple options for patients.
And this is last question by one of the academic junior faculty. You nicely mentioned, he said that high-risk MDS trial has become a graveyard since past 20 years or plus. So what do we suggest, what do you recommend to be a successful clinical trial in high-risk MDS to beat azacitidine?
Yeah, this is actually a very good kind of question. And I actually have like a 30-minute talk about this just for this particular question about the issue of all these therapeutic failures in high-risk MDS and why some of those trials have failed. There are a number of lessons that we can learn from these trials. I can give some of the highlights. I think one big lesson is that sometimes we ignore early toxicity in phase 1 trials because those patients are being managed in big centers, specialized centers. And once you go to the phase 3 trials in setting where you have more community docs and not as experienced doctors, some of these early toxicities can become a problem and you have high rate of discontinuation and problems. And this is something that happened with magrolimab, for example. This hemolytic, like the anemia that was kind of a significant problem, became very apparent at the phase 3, but not at the phase 1. I think another important consideration is how do you balance the transplant, and do you have many patients who are transplant candidates or not, because transplant is the most potent treatment for high-risk MDS. And if you have a significant imbalance, that can affect how the drug kind of is performing. And I'll give an example. Venetoclax phase 1 trial, almost 45% of patients went to transplant, and the median overall survival on that trial was 26 months. But many of us were concerned is, can you replicate a 46% transplant rate in high-risk MDS once you go to a phase 3 trial, when we know that most of the patients are older than 70, they have comorbidities. Most of the phase 3 trials did not see more than 10% transplant rate. So I think there are a number of lessons. I'm happy to come at a later date and kind of discuss some of these issues in detail. But I'm still very optimistic that we are going to have a drug that will hopefully break this cycle soon.
Professor Zaidan, thank you so much again for disseminating the knowledge to help our patients. I wanted to thank all our live audience for joining the webinar. And for those who are not able to join, full recording of the webinar will be available on IACH website in next 48 hours. This is in line with our mission of Hematology Without Borders. Anyone can view all past recording anywhere in the world, anytime. Thank you all again. And Professor Zaidan, we will come back again for your 30-minute session on high-risk MDS best planning of clinical trial. Thank you so much again.
Thank you so much. Bye-bye.